If you're 12 and above and previously vaccinated, it's time to go get an updated COVID-19 shot.
With fall and winter on the way, the United States rolls out new vaccine boosters in hopes of staving off a surge in COVID cases. Hello, I'm Anand Naidu, and this is The Heat. Based on past experience with seasonal colds and flu, public health experts are warning of a possible surge of COVID-19 cases this winter. That's in part because cold weather forces people indoors where airborne transmission thrives, and the now dominant BA.5 Omicron variant is known to be highly contagious. So this month, the United States endorsed new combination booster shots of both the Moderna and Pfizer-BioNTech vaccine formulations. They're expected to provide increased and longer-lasting protection against the original COVID strain and, critically, against the newer variants.
Modeling projections show that an uptake of updated COVID-19 vaccine doses similar to an annual flu vaccine coverage early this fall could prevent as many as 100,000 hospitalizations, 9,000 deaths, and save billions of dollars in direct medical cost.
Right, there is much to talk about. Let's get to our panel. Peter Chin-Hong is a professor of medicine and an infectious disease specialist at the University of California, San Francisco. Kate Tulenko is the founder and CEO of Corvus Health. Also with us is Melanie Yazzie. She's an assistant professor of American Indian Studies at the University of Minnesota. And William Haseltine is back with us. He's the chair and president of Access Health International and author of the new book, A Family Guide to Long COVID, Questions and Answers. Thank you, everyone, for being with us. Bill Haseltine, let me start with you. Congratulations on the book. We will talk about it a little later in the program. But first, let's talk about the potential surge in COVID-19 infections here in the United States. And looking at the numbers, 2/3 of Americans are vaccinated, but only half of them have received a first booster shot. And then we have about 32% of individuals from eligible groups who've received the second shot, and those eligible groups include people who have pre-existing conditions or are elderly. So looking at those numbers, what do you make of them as we head into the winter season?
Well, it's not sufficient. We know that the third dose makes a very big difference in protection from serious disease, hospitalization, and death. People should get the third dose, and I would suggest they should, as recommended, get the fourth dose of the combination vaccine this fall. It will make a significant difference in slowing or in reducing the number of seriously ill people, and unfortunately, those people who may also die. It can really reduce that. So it's an important step for most people to take.
Now, the BA.5 variant, Bill, that's responsible for about 90% of infections. That's as of August 25th. We know that it's extremely contagious. So given that, what can you tell us about the effectiveness of these new reformulated booster shots?
Well, if you look at the sum total of the data that exists on the neutralization of Omicron by Omicron and Omicron variants, and BA.5 is an Omicron variant, is pretty good. It's better than neutralization of the virus by the previous vaccine to the original Wuhan strain of the virus. So it is recommended. There are questions: should it be an Omicron alone? Should it be a combination? We have only right now approved in this country, the United States, the combination. So that's what I plan to take, and I suggest that others do too. There are still other variants out there. There's a very modest variant of BA.4 called BA.4.6, which is very similar to BA.5, but may be slightly different. It does seem to be neutralized by the Omicron antibodies.
Peter Chin-Hong, there have been about 200,000 deaths in the United States just this year alone from COVID, and it's on pace to remain the third leading cause of death among the most vulnerable. How prepared is the country? What are you seeing, and how does it compare with the pandemic at its peak?
Well, Anand, I think now with about 400 to 500 deaths a day, it pales in comparison to 2,000 deaths a day, which we were just over the winter period. But on the other hand, are we really ready as a society to have something that's about several-fold higher than a normal year of flu? If it settles down to 100,000 to 250,000 deaths a year, which is more than diabetes, more than other respiratory diseases, that new normal may be unsettling to many when the dust has settled.
And we were talking a moment ago about the need for people to take these vaccinations. I mean, what more can be done?
Well, I think it's different strokes for different folks. And although the Biden administration has prioritized vaccinations, there are other interventions that people who are not vaccinated can take, including early therapy like Paxlovid, monoclonal antibodies, remdesivir, and other interventions. It's just that there are many barriers for people to even have access to these early therapies.
Kate Tulenko, there have been something like 95 million COVID cases and 1.06 million deaths here in the United States from COVID. And even before the next surge kicks in, looking at the numbers, 320 people are dying each day. And Dr. Anthony Fauci, who is the president's advisor on COVID, says COVID boosters will in future be recommended on an annual basis. Let's listen to what he had to say.
It is becoming increasingly clear that looking forward with the COVID-19 pandemic, in the absence of a dramatically different variant, we likely are moving towards a path with a vaccination cadence similar to that of the annual influenza vaccine, with annual updated COVID-19 shots matched to the currently circulating strains for most of the population. However, some particularly vulnerable groups may continue to need more frequent vaccination against COVID-19.
So, Kate, looking at how this virus continually mutates, does it mean that the vaccine to counter the spread of infection will have to be continually reformulated each year?
It probably will have to, because the COVID does have a mutation rate that's more similar to influenza. We know we have to make a new influenza vaccine every year, so I do expect so. And as far as what people can do to protect themselves this year, we definitely need to get vaccinated against COVID, but also against influenza. I think people have forgotten about that a little bit. And I don't expect this winter to see many new variants. I think Omicron is so infectious it will remain the dominant variant. But we could see mixtures of COVID and flu together and see new recombinants like that.
Yeah, but the numbers are still very high, Kate. At the beginning, when this pandemic initially broke out, we saw a big focus on education. People were talking about this. There was a lot of information being put out there. Do you think we've lost some of that?
It's hard because it's become so politicized. We still need to make the efforts and get the information out there in a way that people can understand in the appropriate, cultural and political context. A lot of education, of high-risk groups, also of areas in which people haven't gotten vaccinated.
Melanie, welcome to the show. Great to have you with us. The Centers for Disease Control recently reported that life expectancy among Native Americans from 2019 to 2021 dropped from nearly 72 years to 65 years. That's quite a drop. That's 7 years. COVID was largely to blame for this drop. Native Americans also experience substantially greater rates of COVID-19 mortality compared to other race groups in the country, compared to other ethnic groups in the country. What's driving these very alarming numbers?
Sure. So an NPR story that came out on August 31st also reported that this is the lowest life expectancy rate for Native people since the 1940s. So COVID, in addition to some of these other pre-existing conditions, have pushed us back 80 years in terms of life expectancy for Native people, which is shocking because the state of Native nations and Native people in the 1940s was deplorable prior to certain types of self-determination acts, particularly in the United States, and the kind of funding that came along with granting self-determination and formal Native nationhood to certain Native nations in the 50s, the 60s, and the 70s. And so what we're seeing essentially is the pre-existing condition, honestly, of colonial occupation of indigenous lands. I think the failure of the United States to allow Native nations the space to practice sovereignty over public health, to practice sovereignty, to close their borders. And in fact, I would argue that during the COVID-19 pandemic, we've seen Native nations have much stricter and long-term policies when it comes to COVID-19, and has actually created a model, I think, a model for how other nations can handle COVID-19 that the United States just frankly just hasn't, both in Trump's administration and in Biden's administration. And so it's really the pre-existing condition, right, is a structural condition, kind of the continual denial of kind of Native autonomy at the nation level to be able to enact these policies. I will say that my nation, the Navajo Nation, still has a mandatory mask. Masks are still mandatory in public spaces, and so that hasn't been lifted, and in all likelihood it won't be lifted. And so I think that itself is kind of a model of how we can go about. I mean, we can talk about vaccines, but frankly, I really wish people were still masking in the United States at the rates that they are in many of the indigenous nations here.
But on overall healthcare, Melanie, what would you like to see change right now?
Right now, I mean, honestly, it's really about masking, and it's about the populations that are outside of reservation boundaries or the boundaries of Native nations taking responsibility for not transmitting the disease to Native people, particularly Native elders. I mean, everyone knows it was, world headline news back in 2020 and then into 2021 that Native people, in my nation specifically, were one of the hardest hit places in the entire world during the pandemic. And this is indigenous land. The United States sits on indigenous land. Indigenous people didn't go away. And so it's really the responsibility and due respect from non-Native people who live on Native land to do their part to caretake Native people who, again, are like one of the most vulnerable populations in the entire world when it comes to COVID-19.
Right, and one other point, Melanie, as you pointed out, Native Americans don't have control over the public health system. So who is controlling it right now?
It's a complicated picture. I mean, privatized care is the same for Native people who have health insurance through their employers, for example. But it's really the U.S. federal government that runs the Indian Health Services, and that's the primary point of contact for most healthcare that Native people experience in the United States. And I mean, all you need to do is go out and collect oral histories or testimony from average, everyday Native people, kind of the horror stories of interacting with the Indian Health Service, which is a chronically underfunded and I think oftentimes culturally inappropriate space for Native people. In fact, there's kind of a running joke in Indian country that a Native person will be waiting until like their foot falls off before they go see the doctor because the Indian Health Service has such a poor reputation amongst Native people. And so there also needs to be a vast improvement and more resources that go to healthcare for Native people. And also Native nations need to be given more resources, but also need to be in charge of what that healthcare looks like. And I think those are important steps moving forward.
And Bill Hazeltine, looking at how COVID is impacting Native Americans, I mean, there's some numbers that I looked at that seem counterintuitive because this, according to CDC numbers, that is, I mean, according to the CDC, vaccination rates among Native Americans are higher than among African Americans or Hispanic Americans. So given that, how does one explain then the higher mortality rate?
Well, the fundamental explanation was already described, and that is the poor health conditions of the Native American population. This has been a very long-standing problem, both with respect to the incidence of the predisposing factors to serious disease and death, which include obesity, diabetes, and other chronic health conditions, lung conditions, for example. So this is not exceptional. If you look across the health indicators of the Native American group as compared to other groups in the U.S., there are very stark differences. And we know that the COVID, despite the fact that vaccines do protect to a great degree from hospitalization and death, they certainly do kill people who have pre-existing conditions, as well as those who are immunocompromised and let's say over 70 or 80.
Peter Chin-Hong, life expectancy in the United States as a whole has been in something like a free fall recently. Again, looking at the CDC figures, it tells us that life expectancy generally from 2019 to 2021 has gone down from 79 years to 76 years old. Other countries have recovered from COVID, but the United States continues to decline. I mean, how does one explain this in the United States, given that it has a pretty extensive healthcare system? It's also one of the most expensive healthcare systems in the world. But how does one explain that drop in life expectancy?
Well, there are two main buckets, Anand. The first is, of course, mortality loss due to COVID, which was not only worse in the United States during the previous administration, but continued during this administration, really speaking to the depth of lack of access, disparities in healthcare, et cetera. So that's COVID healthcare. And of course, the other aspect is, of course, the healthcare that was missed, prevention, treatment for cancer, chemotherapy, heart disease, et cetera, during a time when a lot of things were shut down. You might say, well, how come it hasn't recovered? And that's because we're not really quick and nimble. We don't have a national healthcare system. It's all patchwork. It's all catch as you can based on where you are. And you heard Melanie's articulate representation of the effect on Native peoples.
Okay. Kate, if we look at hospitalizations, they're down 75% and deaths are down 85%. That's from the peak of last year's Omicron surge. We're also seeing that people have put away masks and they are stepping out right now. They're getting into gatherings, and that includes sports events where there are large numbers of people. It also includes concerts where you get a lot of people in a confined space. Is this too much too early? Is it misplaced confidence?
Well, the challenge is that the current situation has become normalized. We have about 500 people dying a day, and that's the equivalent of a jumbo jet crashing and everyone dying on it. But that's become normalized, and I don't think that as we go into winter and COVID rates spike, I don't think we'll see masks required in public spaces. I don't think we'll see them required on planes. I do think that some private employers will, reinstitute mask requirements, but we're definitely not going back to the restrictions of the past, because I think that between the politics of it and just people being exhausted, that it's just not possible. But I do think that this winter we're going to have to reckon with the damage that's been done to our health system. Many health workers burn out, many people leaving the job market. I think we'll also have to reckon with long COVID. It's estimated that about 14 million Americans have long COVID, about 4 million Americans unable to work because of it. Also in the healthcare sector, we're seeing increased numbers of strikes. There are probably about 10 nursing strikes going on. And so all of this will need to be addressed.
Bill, what's your opinion of that? Have we opened up again too soon?
Well, there's really not a choice when the whole population decides what it wants to do. I think what we're learning is that politicians follow the population. And it's very clear to me, by looking at my contemporaries, by looking at my friends, by going from time to time from my country home back into the city, that people have just given up. The common belief amongst most people as well, it's over, isn't it? Well, you've highlighted it's not over. And it's not over in terms of the number of people infected, very large. It's not over in terms of the number of people hospitalized, 30,000 plus. It's not normal in terms of the number of people dying, but it's also something that most people don't really consider, and that is long COVID. It's something that's slowly coming into the consciousness, and I'm glad that it was mentioned before, because about 2% of people who are infected suffer very serious consequences, and that's where you get the number of people who are really suffering. Between 2 and 14 million people, 2 million people to 4 million people can't work. And the chances that you're going to get long COVID is not related to the other pre-existing conditions. The main group affected by that are middle-aged people, people who are between, say, 30 and 60.
Right.
So you could get a mild case, you may not even know you've had it, and you might suffer the very long-term consequences. So the cost that we are going to bear as a society going forward is extremely serious. And I would say our term long COVID is now only measured in months and a few years. If you look at the 1918 flu epidemic, the long tail was measured in decades. I knew as a young person people who suffered long-term consequences from being infected in 1918.
I want to get back to that in a moment, Bill, but I want to go to Melanie. Melanie, talking about people who suffer very serious consequences from COVID, there was a New York Times article recently about COVID among Native Americans, and it began with a story about a woman called Carol Schumacher. She's a member, like you, of the Navajo Nation. She lost 42 members of her family to COVID over the last few years. Have you come across other incidences like this, other stories like this?
Yes, absolutely. 42 is extreme. I've definitely had friends and relatives in the Navajo Nation and kind of more distant kinship networks who lost anywhere between 4 to 9 people in their family. And to speak about long COVID in cultural terms, let's say, to use that language to talk about the long-term impact for Native people, of course, we know that, I'm not sure about Omicron, but the previous variants of COVID-19 impacted elderly people more than others. And we lost a lot of elders. And of course, for Native people, language and cultural retention, the movements to revitalize, especially because the number of fluent language speakers and cultural practitioners is shrinking by the day for many Indigenous people all across the world, certainly for the nations that are occupied by the United States. And so the long-term impact and what we're going to need to do and what we're going to need to mobilize as Native people to address the sheer loss of linguistic and cultural resources because of the losses people is something that I think we haven't even started to reckon with or wrap our brains around how we're going to do this. I do remember last year in an article in theworld.com that a Muskogee Creek spokesperson said that every time we lose an elder, it's basically like losing a textbook. And I think understanding it in that regard, I'm a scholar, right? I write textbooks, I teach textbooks. It's incredibly devastating, the cultural dimension also of COVID-19 and the long COVID and the loss and the repercussions.
Peter Chin Hong, of course, there are all kinds of projections out there, but one of the more pessimistic scenarios that I've seen was one, and this was a group of scientists who said that if COVID mutates into new variants and boosters don't catch up with, as the virus mutates, then the United States could see 1.3 million new hospitalizations and 181,000 deaths over the next 9 months.
Well, and although it sounds pessimistic, I think that what's really important, regardless of what variant is circulating, is the soil in which it lands. So if the soil is hostile, if the population immunity is high and boosted and up to date, that variant, no matter how scary it looks, isn't going to do much. Look at what happened with BA.2 in Hong Kong. Devastated the elder population, mainly because they weren't vaccinated. So you can have something that looks benign, that would act scarily in an unvaccinated person, or something that looks scary, but won't necessarily act the same way, even if we got all vaccinated and up to date with the old-fashioned vaccines.
Bill, let's talk about long COVID and your book. Your book is called A Family Guide to Long COVID, Questions and Answers. Now, of course, millions are experiencing these post-infection conditions like fatigue, brain fog. Some of them have had these things for up to 2 years. Firstly, what exactly is long COVID?
Long COVID is a constellation of symptoms. The way I define it is any serious impairment in health that lasts longer than 3 months. That's not the only definition. There's, for example, that includes damage to your heart, your pancreas, so you become diabetic, your kidney, so you may need a kidney replacement, a whole series of measurable damage to your vital organs, including your brain. Other definitions say if you define it that way, it's a bigger problem, but you can define it as absence of any clear organic organ damage. And that's a much vaguer definition. People are struggling to see if there are markers, biomarkers. People are beginning to think there may be. But I think the sum total of it is, regardless of how you define it, There are large segments of the population that cannot work.
Right.
They are too tired, they are damaged, they can't think properly. And that's what I think of as long COVID.
Now,
and there's a very serious problem, one sec, that I think many people on this call will recognize. And that is, if there's a diffuse presentation, doctors are very likely to dismiss it. The common, as we interview people, the commonality is, oh, you're just hysteric, or you just have some problem at home. You're not really sick. We don't know what to do to treat it. That's the biggest barrier, as it is with a number of other serious diseases.
And very quickly, Bill, is there any way to counter it? I mean, could we see perhaps some kind of vaccine that might counter that or take that into consideration, or even other new medications?
The answer is hopefully yes, but at present we don't know if that's the case. Vaccines seem to have a very modest effect on the long COVID, perhaps decreasing the frequency about 15%. But that's not very much, considering the fact that it's about 90% effective at preventing serious disease in people. And there's no real drug that you can take yet, no real preventive measure. The best thing we can do is to prevent getting COVID in the first place, which is what we're talking about. We're about to have another big epidemic, very likely. We don't do our ventilation properly. We're not wearing masks. We're congregating. It's going to be a continual problem and a growing problem for both short and long COVID.
Kate, very quickly, I've got about a minute left. You know, there are doctors who say, yes, there's going to be a high rate of hospitalizations or infections, then hospitalizations and deaths as well. But it won't be as high as it was, and that is mainly because there's a large segment of the population who now have some kind of immunity. Will that bring numbers down?
I think that will be the case. I think between those that are vaccinated and those that have had COVID, we won't see the numbers as high as they were in the past. But we still will see numbers that will stress the hospital system and make it difficult for other people to access care.
Okay, and that's where we have to leave it. Thanks to all of you for being with us. That is it for this edition of The Heat. I'm Anand Naidu in Washington, D.C. Thanks for being with us.